So this is actually the first time that I'm giving this talk. So it's been a 25-year slog for the founder of the organization, Michael Milken, who many of you know is a financier and philanthropist and a prostate cancer survivor himself, who has been philanthropic in many medical research arenas over the decades. So he also needs no introduction. I don't need to tell this group that this is an important disease. With deference to the urologists, we don't cut hairs between Gleason 3 and Gleason 4. We're interested in developing new therapies for patients that potentially might actually die from the disease. I'm going to talk a little bit about our business overview, leadership, our programs, and partnering with the organization. I'm going to look back a little bit over some of the achievements and look forward to some of the really exciting things that we continue to fund. So we've now put over $700 million into the field, and I think the title had something to do with leverage. That $700 million must be worth billions by now in the drugs that have come out of this work. We're all over the world in 19 countries globally, 200 cancer centers and universities. So, some of the main achievements that Michael Milken is most proud of, I share that pride, is that we sort of took this disease out of the closet. And there are 50%, the death rate is down by over 50% compared to what it was supposed to be. Part of that is due to better surgery, better radiotherapy. A lot of it has to do with better awareness of the disease that I think can be credited to our foundation. We've streamlined the funding of medical research. I know the investigators spend enormous amounts of time writing grant proposals, getting rejected, and it's just much simpler. We unfortunately have to reject a lot. It's a fiercely competitive process, but it's a very streamlined procedure. We've recruited into the field, just one example of somebody that really didn't know where the prostate was located before we funded him first was Charles Sawyers. He's a leukemia doctor at UCLA. And we asked UCLA, who are the best and brightest people you have? And here comes Owen Whitty and Charles Sawyers and all the rest. So we've brought great people into the field. We've built a global awareness, and we've collaborated with many companies, governments, and as well as universities. Just some examples, and we'll talk more about these, where we actually funded the seed that started the tree, which is Yervoy, Xtandi, and Zytiga, and I'll have much more to say about each of those. But really, every FDA-approved product that Chuck talked about in prostate cancer has our fingerprints on it. So who's on the team? Well, I told you already about Mike Milken. My mentor, Skip Holden, who has forgets more about urology every day than I'll ever know, guided me in my early years. And scientifically, having Jonathan Simons as our CEO and having at least 4 hours a week where we shut the door and talk about science is pretty amazing. And then a great team around us of administrators that makes everything happen. So just real briefly, we fund team science, we fund young investigators, and we fund pilot awards. And that turns out to be about $35 or $40 million a year in highly peer-reviewed research. In 2017, there are now 27 distinct chemical entities that are first in field that we're funding. So far, 11 challenge awards. That number is going to rise substantially before the end of the years. These are the team science million dollar plus that funds lots of people. We've so far funded 35 35 early career scientists and 22 new young investigators, and that number too will go up before the end of the year. So really the next generation of leadership is one of the aspects of the foundation that I'm most proud of. I don't know if we have any young investigators in the crowd here today. Maybe Chuck, you were young at one time. I don't know. I think you predated this cohort. But we provide a fellowship, and it's really more than just the money. We create a community for these people. I can't tell you the amount of wonderful time I get to spend in career guidance when someone's making a decision. Do I go here? Do I go there? I think Pete Nelson, if Pete's still in the room, Pete owes me a very expensive dinner for one of his new faculty members, but there are many spread around the world that I've helped to try and guide to where I thought they would socially and intellectually do the best. And here are some of them. Let me just point out a few of the real superstars that some of you may know. Nima Sharifi, who's now at the Cleveland Clinic, that was a heavy career guidance award, a guidance time to get Nima to take that position. He's done great. Scott Tomlins, who is a pathology resident, had a laboratory larger than I think most physician scientists at the middle of their career. He's done just so well. Misha Beltran, your neighbor down the street, they are now the proud recipients of a prostate cancer spore grant, and she had no small part in that. Felix Fang, we just heard about luminal A and luminal B and throwing PAM50 against prostate cancer. He is one of the most creative radiotherapists that you can possibly imagine. And Ellie Van Allen at the Dana-Farber, who actually showed up as a fellow, knowing how to code as a bioinformatician and a medical oncologist. He's just knocking the skin off the ball. And there we are celebrating a class last year in La Costa. So what are the treatments? Well, this is really the list. And I could tell you a story on each of these and what we had to do with it. I'll narrow down, but I think, even in supportive care, compounds like the rank ligand inhibitor and Zometa, those just don't exist without our foundation, but certainly the rest. But let's talk about some of them, which were enabled by this thing called the Prostate Cancer Clinical Trials Consortium that we started many years ago that has been taken over by the DoD. They have now, I think Howard Scher told me, have accrued over 5,500 patients. So it's just amazing. And these are all phase 2 trials, so it's a lot of heavy lifting. So docetaxel. Who even thought prostate cancer was a taxane-sensitive disease? And when I joined the organization, believe it or not, in 1997, I was aghast. I came out of the cardiology, cardiothoracic arena, drugs for heart disease, stroke, clotting disorders, et cetera. And when I saw the 5 patients, 10 patient, 15 patient clinical trials, I thought, what are you guys doing? But it really took that slogging through the early clinical trials to show that this drug was actually active in prostate cancer, and this was the first drug shown to prolong survival for advanced disease. The one that we're probably the most proud of is enzalutamide. Charles had a hypothesis that the androgen receptor was mutated and overexpressed in what was then called hormone refractory disease. Boy, were we wrong. In fact, Simons will tell you that if you worked at Hopkins at the time and you even proposed doing something around the androgen receptor between Dr. Walsh and Dr. Coffey, they would probably fire you, because everything that we knew about the androgen axis we had figured out when urologists were doing orchiectomies on these patients, but that really wasn't true. Wasn't true at all. And this team came together. And when you start talking about the cost of drug discovery, which is a hot topic today, this team did the biology, and Michael Jung, the chemist, did the synthesis atom by atom to what is now called enzalutamide. And I find myself re-educating companies like Astellas and Pfizer and the former Medivation over and over that if not for PCF, this never would have happened because Charles never would have been funded and would have kept working on leukemia. And the drug is active in many different clinical settings, and as you all know, is FDA approved. So Abiraterone is another interesting one, and when Arie Belldegrun first licensed it, he called me up and said, I'm starting a new company called Cougar. This is true, Chuck. I can't make this up. And I've licensed this compound from the Royal Marsden Hospital. It's probably a little bit better than Nizoral. Urologists will love it because it has lower side effects than ketoconazole, Nizoral, et cetera. And it was really Pete Nelson and the group that showed that Abiraterone was more than just an adrenal androgen inhibitor. These guys slogged through the research lab to show that it was an intercurrent androgen inhibitor, which was first in class. And you know, the work that we funded, that we actually continue to fund now, studies of mechanisms of resistance of Abiraterone and enzalutamide as well, is really a great achievement from the foundation. And thank you, Pete, for bringing along so many people. I mean, I don't think people wanted to believe it at first, but it's real. And intercurrent androgen synthesis, the fact that the tumor could produce its own fuel, was hard to understand at first, but now we know a lot about it and understand the mechanisms down to very, very fine detail. So yes, it's been approved in a number of settings, and we're very happy about it. There was already a talk this morning about moving these drugs up front. Latitude. Stampede, by the way, is a force of nature. Raise your hand if you know what the Stampede trial is. So in the United Kingdom, how many years ago, Lori? Probably a decade at least. A very smart group of people came together and said, we really don't know enough about how to treat prostate cancer from diagnosis to death. And they put into place a series of clinical trials, randomized clinical trials. And now patients really aren't treated for prostate cancer in the UK. They're diagnosed with prostate cancer and they're treated on the Stampede trial. So one of the first Stampede results was showing that, upfront taxane chemotherapy with androgen deprivation therapy prolonged survival, just like Sweeney's trial charted. Probably, I haven't done the math, but the prolongation in survival is about 10 times longer than all the other drugs put together to treat advanced prostate cancer. It's really quite amazing. It could be a lead time bias, probably is, but it sure feels right. So Abiraterone up front now, if we can afford it before it becomes generic, will become probably the standard of care in these patients. So this is an interesting case here. Drugs we had hoped would work in prostate cancer but didn't. And there are a lot of them actually. So let's start with one that is called Bortezomib. And this story you also could make up. My friend Julian Adams, who's probably one of the finest medicinal chemists of his generation, had this proteasome inhibitor and was working with Dr. Logothetis and MD Anderson. And they called me one Wednesday morning and Julian said he couldn't rub two wooden nickels together to make a dime. The company, I can't even remember the name of it right now, that he was developing this drug in was going out of business. They just couldn't raise any money. And Logothetis believed in it. Far be it for me to criticize Dr. Logothetis' clinical machismo. And they said, if you can just come up with a little bit of money for a phase 1 trial, we'll test it in prostate cancer and a few other tumors. Well, we did, based on my respect for Julian and Chris. And we did fund a small trial. It was oversubscribed by prostate cancer, who all received nothing but toxicity from this drug. And there were a few multiple myeloma patients in there, and I think we all know that Velcade is standard of care for multiple myeloma. So it didn't work for prostate cancer, but it did work for multiple myeloma. Here's another one. Jim Allison was slogging it out at Berkeley, curing rats of melanoma for, probably 15 years. Nobody wanted to believe that CTLA-4, this new sort of immune checkpoint, was real or important, and he was ready to hang it up. So I went over to Berkeley and visited with him, and I had known Jim for quite a while, and brought him over with a little bit of money to UC San Francisco, where Eric Small gave him a spore project, which also was rated pretty low, but a good spore project in our opinion. And the first patients actually treated with Yervoy, ipilimumab, were prostate cancer patients at UC San Francisco. Didn't work, just didn't work. Maybe we understand now, I don't know, I think the days for Yervoy are kind of numbered because of the success and limited toxicity of some of the newer checkpoint antibodies. But melanoma patients everywhere should thank our foundation for what we did to save this and give Jim the money to keep it alive before it could be licensed by a major pharmaceutical company. And there are many others. So precision medicine. We invested in a program called MyOncoSeq, which is, Michigan OncoSeq. People come up with great numbers, great anagrams for these things. And when it started, it was Ken Pienta, the immense leadership of a molecular pathologist, Arul Chennaiyan, and Samik Roy Chowdhury, who was a medical oncology fellow at Michigan, who actually did the heavy lifting for this first course of precision medicine in Ann Arbor. Samik is now a faculty member at Ohio State University and doing great. So the complexity of setting up precision medicine where physicians could actually act on the results was remarkably complicated. And I know you can't read this, but assume that these tumor boards that had never been done before required not only medical oncologists and radiotherapists and radiologists and pathologists and bioinformaticians and basic scientists, pharmacologists. It also required bioethicists. And they figured out how to do all of this, and that's now become the roadmap for all precision medicine tumor boards. This morphed into the Stand Up to Cancer Prostate Cancer Foundation International Dream Team. There actually are two dream teams, but we'll only talk about this one for now. What a cast of great people with, Dr. Nelson up in the Northeast, all the way to Dr. De Bono at the Royal Marsden in London, and everybody in between that you can possibly imagine, led by Sawyers and Chennaiyan. It's a great team. I always put the PCF before the Stand Up to Cancer because we provided all the money. By the way, Stand Up to Cancer didn't want to fund individual diseases. They wanted to fund things like epigenetics, and we convinced them that they should fund prostate cancer. And I think even Phil Sharp will tell you that this has been one of the most productive of all of their dream teams. I'd have to agree with that, which resulted in 2015 of this landmark paper in Cell, with showing some things we sort of knew already and some things that we learned. Probably the DNA damage repair aspect to advanced prostate cancer is something we didn't really know about until this came out, described even better by the group in Seattle, and we'll talk about that in a minute. But this is probably, as I go around the world to prostate cancer meetings, probably the most highly projected slide, most frequently projected slide in everybody's talk, because you can't do prostate cancer science or clinical pharmacology without thinking about this. So if I can call on the pathologists in the room again, this thing about neuroendocrine prostate cancer continues to plague us. I think we're getting closer. It took 3 workshops of expert pathologists to actually figure out how to call these things from metastatic samples. And then we had Jiao T. Wong, and we had Jonathan Epstein, and all the right people, Mark Rubin, And still it was like, I couldn't take it. I skipped the third one, and it was in LA. But they worked very hard, but even more so, Misha Beltran, and now more recently, the UC San Francisco team, led by Felix Fang and Mark Root and Eric Small, have given molecular characterization to what's called neuroendocrine prostate cancer. And this gets back, this is somewhat of a treatment-induced phenomenon. It's a really bad form of the disease that nobody really ever wants to have, and gets back to what Dr. Drake said earlier. What is going to be the overall effect of putting these androgen axis inhibitory drugs, these powerful drugs, up front? Will you hasten the development of this bad kind of neuronal transdifferentiation, or will it not make any difference at all? And I think it's a pretty scary experiment that will be done clinically. And I would say probably the most important finding in the last 15 years, at least, is the work of Peter Nelson and Colin Pritchard at the University of Washington, the Fred Hutch, on this very, very curious discovery of a high preponderance. What number can we use now, Pete? Like almost 20%? Is that safe? 10% inherited, but in the cases, how many will you find in the cases? About 20. That's huge. So of these so-called DNA damage repairs, and the reason I asked Dr. Zalewski the question I did is that it's still a very complex, and there are many smaller components to this DNA damage repair cassette that we need a lot more research to understand. But just the fact that they're finding, I mean, this is, whether it's for PARP inhibition or whether it's for platinum chemotherapy, I think there's some data in here a little bit later about platinum chemotherapy in this cohort. It is absolutely a treatable disease based on the findings of Nelson and Pritchard in Seattle. I'll take one. So another great investigator from Dr. Nelson's group is a young medical oncologist named Heather Chang, who actually created the first, well, let me back up. The finding of these inherited mutations in men with advanced prostate cancer is a dilemma for the treating physician, because the implications for the family should be obvious to this group. Genetic counseling, and I've actually gone to genetic counseling myself, not that I have a germline mutation that I know about, but I wanted to understand what this process was like. And so you get a master's degree sort of technician. This woman was well-spoken, but basically reading a script based on the disease of concern. And she had no idea. I actually did this like just a few days after the New England Journal paper came out from the Seattle group, and she had no idea of what I was talking about, that this was important in prostate cancer. She knew about breast and ovary cancer, but not prostate cancer. So having a hard professional, a medical oncologist, an MD, PhD like Heather Chang, actually start the first genetic counseling program for prostate cancer patients and their families has been a huge, huge benefit to the field. And now as I go around, Kathy Cooney has one in Utah, and there's a high-risk clinic, I think the next one, yes, high-risk clinic at the University of Michigan, led by a young urologist named Todd Morgan. So this is catching on like wildfire. But if you think about the number of patients that probably should receive genetic counseling, the number and the expertise is quite deficient today, and hopefully people like Heather Chang and Todd Morgan will change that coefficient. Okay, another one that we're really proud of is the PARP trial. I don't know if Dr. Zalewski has gone back to the clinic already, but this was a trial based on a Prostate Cancer Foundation Challenge Award to these people: Karen Knutson, Johan de Bono, Felix Fang, and Mark Rubin. You see a pathologist, a very good pathologist, and a radiotherapist, a medical oncologist, and a basic scientist. So they came together in this as part of the Stand Up to Cancer Prostate Cancer Foundation Dream Team, and did the science to really allow AstraZeneca to, or convinced AstraZeneca to invest in prostate cancer, whereas everybody else was running off to breast and ovary cancer with their PARP inhibitors. So that is now in phase 3 clinical trials. And the actual New England Journal of Medicine paper was amazing data. But I will back up again and say that the patients that were not selected for DNA damage repair alterations, they were all comers. And it wasn't until the end of the trial that they deconvoluted the genomic landscape of these patients. Many of them had DNA damage repair defects, which with hindsight made it easy to explain why they had responded, but many didn't. So we have a lot more work to do, and I'm glad to see that at least the AstraZeneca trial keeps that in mind. And so they have patients with, if I'm not mistaken, in one arm, BRCA 1 and 2 alterations, I think ATM as well, and then another arm for any of these other 250 genes that de Bono teased out of the PARP cohort. As we go forward, we now already have to deal with mechanisms of resistance. And these are 3 PCF young investigators. Young Joaquin Mateo, who's going back to Barcelona from the Royal Marsden, and soon will have his PhD from Dr. de Bono. David Quigley, who's working at UC San Francisco with Felix Fang and Alan Ashworth, and Felix Fang himself, who is recently relocated to the University of California at San Francisco, a very rare radiotherapist who was actually trained by Arul Chennaiyan in genomics at Michigan. This is a dream team in and of itself. And you may have seen the recent paper that there are actually reversion mutations to BRCA that define a great number of the resistant patients. So now we got to do something about that. Okay, I'm also interested in the use of old drugs. I like old drugs. And my buddy Bruce Montgomery from the University of Washington and I have spent hours talking about BRCA and not PARP, but platinum. A bag of carboplatin costs about $100. PARP, 30 days of PARP inhibition will probably be about $8 or $10 or $12,000. So platinum, medical oncologists know how to use it. They're skilled in it. The dose given to prostate cancer patients, Chuck, keep me honest here, is a lot less than it is, a lot lower than it is for many other human solid tumors. So Heather, you can see here a patient that had responded very poorly to standard of care and was given carboplatin, docetaxel, and had a great response. Here's another one. Just, disease getting out of control. And these all, by the way, had BRCA alterations and responded. So there's really there's a good reason to do this, and Bruce and Heather and others up in Seattle and Matt Radig at UCLA have a Veterans Administration clinical trial for platinum therapy in men with castration-resistant prostate cancer that have failed androgen axis inhibition. And this is the trial. So just to say, we have a number of expanding programs in the Veterans Administration Hospital. And we have our eyes on the Manhattan VA, by the way. We think I don't know, I know that NYU staffs that hospital, but Chuck, we'd like to see patients go on your trials out of the VA as well. And that can be done now. It's actually positive to do clinical trials at VA hospitals, which just a few years ago wasn't possible at all. Okay, so how are we going to reduce precision medicine to real practice? And Stratify is the name of one of these trials, and Catch is the other. Catch actually came first, and I have to give attribution to Arul Chanayan for this. But I recently heard this presentation at UC San Francisco. Strata is an interesting company that will sequence DNA for free and in a CLIA setting and give it back. And Scott Tomlins, the pathologist in the group, is one of the founders of Strata, and they can scale. They're really a very impressive young group. So other than the sequencing, Stratify is the same as Catch, which was born in an NCI meeting a couple of years ago. So really, what's the goal here? They want to match, in this study, 10,000 men with advanced prostate cancer to drugs, which is easier said than done. And the goal here, the goal is to accelerate the enrollment in precision medicine trials, because right now it's one-off. I'm going to skip that. And this is like almost impossible to read. This is actually a Chanayan slide. This shows the flow, but I think scientifically more interesting, these are the targets. And I know one in particular that Pete Nelson is interested in, the fibroblast growth factor axis. I mean, the complexity in just getting that drug from some company for a clinical trial is huge. And those of you that have gone out to get drugs for clinical trials know how complicated and frustrating and time-consuming it can be. So we're challenging this group, we're challenging the Ann Arbor group. We got to get the drugs. Once you can get a couple of these drugs, then we're going to fund this in a very big way. And here you go, one example. So I'm not going to say much about ARV7. It's been so hashed over, except to say that I get to have the bully pulpit here and say I believe that it is an important prognostic factor and probably not a therapeutic target. Does everybody know what ARV7 is? So this is a splice variant of the androgen receptor. And it's not uncommon for cancers to aberrantly splice genes when they are stressed. And by the time patients become resistant to androgen deprivation therapy and the other new medications, they are highly stressed. And ARV7, the splice variant, which is missing the ligand binding domain of the receptor, but constitutively signals an androgen receptor a gene expression profile mainly described by Pete Nelson. It's very cool. And an early study from Hopkins showing that it is a resistance mechanism to enzalutamide and abiraterone, no question. I think it's been studied in CTCs. It's being studied through genomic sequencing. It's been studied every way you can believe. So we'll just say that ARV7 is a bad prognostic factor, and if anybody wants to challenge me on the pharmacology, I'd like to do it. We hear a lot about liquid biopsies, a lot more complicated than anybody would give credit to. There are companies now that offer it. And I would have to say that it's an extremely naive clinician that would blindly send a plasma sample out for tumor DNA sequencing at this point in time. So what we've done to help, this actually was born in the Cincinnati airport, this idea, is PCF Select. And it includes diverse investigators from England, from New York, from Italy, from Canada, Switzerland, I'm sort of sad to say, from St. Louis, from Boston, and another one from Vancouver. It's a bake-off. They're splitting samples, and we'll see who comes up with the best test. And they're going to take the sheet off of this, and we're going to take a look under the hood in just a couple of months. So I'm really excited about PCF Select. But recently, in my visit to Seattle, Colin Pritchard is working, the pathologist in Pete Nelson's group, is working very hard to perfect a test up there. And I know, Pete, it's a lot harder than anybody gives it credit for. And the discordance between what an academic clear result is and one of these commercial outfits is a big concern. So I'm just going to blow through some of what I think are the most interesting new treatments in the next few minutes here, and then we will conclude. So let's talk about CAR T cells, since everybody's talking about CAR T cells. We have funded Carl June, and one of the great hemonc guys in the world, Steve Foreman, who cares about prostate cancer, to create prostate cancer CAR T cells. And I'm happy to report that at the University of Pennsylvania, Naomi Haas treated the first patient 2 weeks ago with a prostate cancer PSMA CAR T cell. Pretty cool. A lot of these you can read. I'm fascinated by the work at National Cancer Institute, combining PARP inhibition with immune checkpoint inhibitors. It's actually olaparib plus durvalumab. It's early days, but as Dr. Drake pointed out, the number of responders with prostate cancer to checkpoint antibodies have been few. There's some luck in Oregon. We'll see how that moves out in the rest of the world. But the combination here of the PARP inhibitor and the anti-PD-L1 antibody has been exemplary. And if it continues, then we will, as we go forward, learn what that mechanism is. I have some ideas that I'd be glad to debate over lunch with anybody interested. Dr. Drake, sitting in the first row here, has been funded, combined for studying epigenetic therapy with checkpoint blockade. And I look forward to seeing some of that data in the not too distant future, Chuck. So protein synthesis is a target. Andrew Shea, again in Pete Nelson's group up in Seattle. If I had to pick a world's expert on protein translation, this guy is like off the charts smart. He's really good. And he has some ideas in the setting of PI3 kinase mutation and loss, how it might affect protein synthesis and how protein synthesis inhibitors might actually work in a treatment of advanced prostate cancer. And by the way, there is an AKT inhibitor from Genentech being studied in PTEN deficient patients at the Royal Marsden. This is an interesting study from Matt Rettig at UCLA. Trametinib, so if you look at the other dream team, the so-called West Coast dream team, they had studied trametinib, actually the expression of MEK it was a spore project for Dr. Ryder's group, and they knew that MEK was overexpressed in the majority of cases of advanced prostate cancer. You can see all the drugs that this patient failed, or the drugs that failed the patient, I should say. And Matt just said, well, if you can afford to buy a bottle of trametinib, it's worth a try. And I think they're now, Novartis is actually funding this clinical trial at UCLA. So TROP2, it turns out, is the Mark's a cell of origin of prostate cancer, defined by Owen Whitty at UCLA. And I was in a board of directors at a failing company named Immunomedics asked me to come to their board meeting where they told me about this TROP2 antibody drug conjugate that they were developing in triple-negative breast cancer. I said, well, that's great, but have you done this in prostate cancer, which is decorated with TROP2 like crazy? And they said no. So I called Josh Lang at Wisconsin, and Josh tested a dozen patients and found TROP2 on their CTCs. And so now that clinical trial has started. And since I'm running out of time, this is another very hot area, PSMA-directed radionuclide therapy. So these are small molecule ligands to PSMA that are coupled mainly to lutetium or actinium for beta and alpha radiation. We just funded 3 of these, one at Cornell, one at the Peter Mac, and one at UCLA. Great sort of one-off responses. We'll see if they're actually true drugs. And I'm not going to talk about imaging because I'm out of time, but molecular imaging has been an important part of what we've done, and we have funded a lot of research in this area. And I will end with our Icecap Initiative, which was started by Chris Sweeney. This was a data pooling exercise. Chris pooled in all the randomized data where overall survival was the endpoint for any stage or grade of prostate cancer. A lot of radiotherapy trials, but many drug trials as well. And they have now published twice. The most recent publication in JCO shows that from this data set, they could mine out metastasis-free survival as a surrogate endpoint for survival, overall survival in prostate cancer, which is, still needs to be proven in a new randomized trial. Hopefully the enzalutamide or the apalutamide upfront trial may actually prove it for us. But this has been a great global effort, and Sweeney is a force of nature not to be reckoned with. So I think I'll end there. I don't want to be the guy that has the red light flashing between you and lunch. Just to say that I probably have the best job in the world. I have an amazing window on everything going on in the field, and more importantly, a very clear window on the people and the sociology of science and medicine. So takes a team. We have a big one, and it sure would be nice to see the end of prostate cancer so we could go on and finish breast and brain and colon and all the rest of them. So thank you very much for your attention.